Bismillah ar-Rahman ar-Rahim. The topic I'm gonna discuss today is what we as neurologists and general practitioner come across in clinic very frequently, and that is mainly related with pain and different pain syndromes. So the topic is fibromyalgia, and I'm gonna explain more about it. So by definition, it is chronic widespread musculoskeletal pain of at least 3 months duration. So as definition, it has to be there for at least 3 months before we're going to label this as fibromyalgia. By etiology and pathophysiology, which is not clear, there are many hypotheses, but it is considered to be a centralized disorder of pain regulation. So there is some kind of pain dysregulation going on in the central receptors in the brain and spinal cord. The prevalence of fibromyalgia as per evidence is 2 to 3% in any population, and it increases with age. It is much more common in females compared to males. According to a UK-based population study, the prevalence of the chronic widespread pain in the population is around 14%, and fibromyalgia as per standard criteria was 5%. So this was a systematic review where they looked at more than 1,700 studies and close to 1,39,000 patients enrolled in those studies, and they came up with this number of prevalence of fibromyalgia in population. As I said, the etiology and pathophysiology is unclear, and more importantly, all the workup, what we do as a clinician in office is normal. So there is no laboratory abnormality, there is no radiological abnormality to guide us about the diagnosis. So what we are left with is history and examination. So when it comes to history, the most common symptom which is noticed in these patients is fatigue, which is also part of the core criteria for the diagnosis. But additionally, these patients are sensitive to any climate change, motion sensitivity, and there could be other psychosomatic symptoms. Neurological manifestations are very common, and especially cognitive disturbance in these patients. Almost 50% of these patients have noted or reported headaches. They have also complained about paresthesia in upper and lower extremity and elsewhere. There could be sleep disorder, including obstructive sleep apnea, periodic movements of sleep, or restless leg syndrome. Again, sleep disorder besides fatigue is also part of the core criteria for the diagnosis of fibromyalgia. As I said, psychiatric manifestations are very common. Almost 30 to 50% of the patients have complained about different psychiatric issues, including but not limiting to depressive disorders, anxiety disorders, post-traumatic stress disorders. In clinical practice, I have also noticed the patients who come across some kind of a sudden trauma. It could be physical or psychological. And later on, they notice this chronic widespread pain syndrome, which is consistent with fibromyalgia, or at least on the spectrum for that. As I'm also an autonomic subspecialist, so I can tell you sometimes these patients do come up with autonomic disturbances. It could be mild, or it could be part of small fiber neuropathy. So this is a particular patient population where you want to do some testing to make sure, and this could be treatable in somewhat different way compared to regular fibromyalgia patient. So these patients may complain about dry eyes, Raynaud's phenomena, orthostatic hypotension. Heart rate variability is hard to assess in clinic, but in a dedicated autonomic lab, these tests can be done to confirm if a patient is having evidence of central or peripheral autonomic disturbance. And as I have already mentioned, these autonomic disturbances could be very annoying for these patients and could be the reason for the clinician appointment. Physical examination most of the time in these patients is normal. The most important finding which has been noticed is tenderness. So beside widespread pain, there is more than usual tenderness to modest pressure points. So these pressure points could be upper mid trapezius muscle, lateral epicondyle, second costochondral junction, greater trochanter, but more importantly, it has to be more than usual tenderness beside the chronic pain the patient came in with. As I said, these patients are sensitive to any climate change, and there has been many other associated disorders which can be noted in these patients, including but not limiting to migraine, irritable bowel syndrome, depression, musculoskeletal pain or arthritis, sleep disorders. So these could be primarily or as part of the associated disorders could be there. And there could be slight changes in the management of the patient based on the associated medical disorder. So certain criteria for the diagnosis has been posed as for any disorder. In this case, it was not really clear, is it a somatic or psychosomatic syndrome? But the first criteria was proposed in 1990, according to the American College of Rheumatology. And then they proposed another criteria in 2010. In 2013, which is the latest AAPT criteria, which is devised by the Action and the American Pain Society in a joint venture. And it includes that it has to be at least 6 or more pain sites out of the possible 9 pain areas. It has to be moderate to severe sleep disorder or fatigue as part of the core criteria, and it has to be present for at least 3 months. So the pain sites could be head or neck, it could be lower back, it could be right or left arm, it could be right or left leg, it could be chest or abdomen. So it involves whole of the body, but out of the whole body, 9 areas, there has to be at least 6 different pain sites to diagnose a patient with fibromyalgia. As you can guess, so based on the different pain syndrome, there is some differential diagnosis, especially rheumatological disorders, including rheumatoid arthritis, polymyalgia rheumatica, myositis can present like that. So we need to be careful in these patients, and we need to do some testing to confirm it. Hypothyroidism could be another, hyperparathyroidism, and for sure neuropathy can also present with widespread pain. As I said already, it is important to understand, is it a primary disorder or there could be associated disorder which can be contributing to fibromyalgia? Because it has to be taken as together, and we have to make sure that we are identifying and treating each individual neurological or associated disorder beside fibromyalgia. So the treatment includes patient education, addressing the comorbidities. Walk and exercise program is something which I emphasize in almost every neurological disorder, or even if you don't have any neurological or medical disorder, walk and exercise should be part of the routine to help you to have a more healthier body and mind. As we start with the treatment in these patients, usually we start with the drug monotherapy, but there could be specialty referral and polytherapy if the patient is not improved. But in my personal experience, I'll say most of the time patient improves with the general advice, which is kind of the scenario in more than 90% of the patients, and very rarely I need to use drug polytherapy. So the drug therapies which we use or we can start with are the tricyclic antidepressants, selective serotonin reuptake inhibitors, selective serotonin non-epinephrine reuptake inhibitors, or anticonvulsants like gabapentin and pregabalin. My usual go-to medicine is serotonin norepinephrine reuptake inhibitors. If there is associated migraine disorder, I may go for tricyclic antidepressants in the start. If a patient is having neuropathy, then you can use SNRI. If there is concern about the weight gain, then I probably tend not to use gabapentin or pregabalin because there could be potentially weight gain with these medications. But we need to be careful about these medications, especially in females of the childbearing potential, which is a usual scenario in these patients because fibromyalgia is more common in 20 to 55 years age group. And most of the females during this time do get pregnant and have babies, and most of these medications are not pregnancy safe. So we try to keep the dose as minimum possible and discuss the side effects, because it is important to continue with the medicine for long period of time to have sustained benefit. Because if the patient uses it for a few weeks to a few months, they may not notice a good benefit and they switch to another medicine, and usually it results in a refractory nature of the problem. If patients who are refractory, we can consider specialty referral, including pain clinic, or there could be acupuncture, hydrotherapy, aromatherapy, or there could be many alternative options available. And additionally, we can try combination drug therapies. Again, you can use antidepressants with nerve pain medicines like gabapentin could be a combination you can use, or you can use some other supplements as well. It has to be a multidisciplinary approach. especially if a patient is having a psychiatric or associated sleep disorder. In that case, we should consult our psychiatry colleagues and refer the patient for the sleep evaluation and get an opinion from the sleep specialist if needs be. So in total, I'll say there are many different pain sites and the treatment course is long. Counseling is the key to patient satisfaction and symptom control. More important, because patient has to develop a rapport with you over the period of time, because you have to develop a rapport with the patient. If the patient quit the treatment in the middle, may not notice a good benefit, and that may not result in good relief of the problem. Thank you very much, and I hope this lecture will be helpful for you in terms of understanding what fibromyalgia is and how we can treat it. But naturally, it takes a specialty referral, including neurophysician or psychiatry or pain clinic, to provide a good relief to these patients, but it involves a good number of patients in our population. Thank you very much.